Oral cavity cancer is our topic of discussion today, and so we'll be discussing it in detail under the following headings: the risk factors, premalignant lesions, pathology, staging, workup, management, neck dissection and complications, and finally adjuvant therapy. So oral cavity, we know it extends from the mucosal surface of the lips to the junction between the soft and the hard palate. So this is the oral cavity. The incidence of oral cancers, it increases with age. Now the mean age of presentation is 62 years. I want you to remember that. Okay, so the most common type of oral cancer, the vast majority, is squamous cell carcinomas. Now moving on to the first heading, which is risk factors. So smoking is a risk factor. Alcohol is a risk factor. Chewing of betel quid, that is a risk factor. Immunosuppressed state is a risk factor, right? We have diabetes mellitus, people on steroids, right? HIV infected, these are immunosuppressed conditions, so that is a risk factor. All right, and then there is chronic infection. So chronic infection means it can be due to Epstein-Barr virus, which causes nasopharyngeal carcinoma. It can be hyperplastic candidiasis. So I said EBV. Then HPV infection. See, HPV infection, it causes oral cancers. 5% approximately, only 5% of oral cancers are caused by human papillomavirus, but 50 to 70% of oropharyngeal squamous cell carcinomas are caused by HPV. So remember that. Now other risk factors will include radiation, immunosuppression, hereditary conditions such as Fanconi's anemia and Leigh-Fermani syndrome. Now moving on to the premalignant conditions. Okay, so just take a look at this summary box for the risk factors of oral cavity malignancy. Alright, so premalignant conditions, majority do not originate from premalignant lesion. So but there are a group of premalignant lesions, they are potentially malignant lesions, okay, that are mucosal abnormalities from which oral cancer can arise. Now these lesions will include leukoplakia, erythroplakia, erythroleukoplakia, proliferative verrucous leukoplakia, oral submucous fibrosis, oral lichen planus, and lupus erythematosus, as well as inherited conditions. We have different inherited conditions. So we have divided these premalignant lesions into high risk lesions. We have divided it into medium risk lesions and low risk lesions. So high risk lesions, we have erythroplakia. We have proliferative verrucous leukoplakia. That is a type of leukoplakia. We will see the types of leukoplakia later on. Okay, and then we have chronic hyperplastic candidiasis. These are the high risk lesions. Now medium risk lesions, we have oral submucous fibrosis and syphilitic glossitis. So low risk lesions, we have oral lichen planus, discoid lupus erythematosus, and discoid keratosis congenita. So the most common site for oral cancers in India, you can guess it could be the buccal mucosa, of course. Why? Because tobacco chewing and all is very common. So in the world, the most common site, however, is the lateral border of tongue. Now let us discuss something known as verrucous carcinoma. So this is a variant of squamous cell carcinoma. It is HPV positive, and the peculiarity of this tumor is that it grows outwards. Okay, it is a slow growing tumor with good prognosis. So what you see here is a verrucous carcinoma. This is also called Ackermann's tumor. This is a slow growing tumor with good prognosis and outward growth is seen, you can see. Okay, now looking at leukoplakia versus candidiasis. So leukoplakia and candidiasis both have white patches. So here you can see it is written here in Bailey that leukoplakia is a white patch or plague that cannot be rubbed off, which is very important to remember. The white patch in leukoplakia, it cannot be rubbed off. It is not characterized as any other condition. Now, what is the management of leukoplakia? Leukoplakia, we manage it. You have to remove the risk factors. We can do a wide local excision. Also, you can give antioxidants. So this will be the management. Now here is the image. So this is a white patch which cannot be rubbed off. Okay, I'll show you the white patch in candidiasis, but before that let us look at the types of leukoplakia. So we have proliferative varicose leukoplakia, right? So this is a multifocal lesion. This does not have any particular risk factor, and it is high risk of developing into a malignancy. So increased risk of malignancy. Okay, now speckled leukoplakia is nothing but leukoplakia with reddish margins. Okay, that is a speckled leukoplakia. So here also excision should be done at the earliest. The management of proliferative varicose leukoplakia is excision at the earliest, and speckled leukoplakia, the management is again excision. So having seen the types of leukoplakia, we are moving on to candidiasis. So here this is how the image of candidiasis is. Candidiasis, the patches can be rubbed off. The white patch, it can be rubbed off. Remember that. So there is a reddish border and there is increased risk of malignancy here also. Okay. Now erythroplakia. So erythroplakia is a bright red velvety plague, neither of which can be characterized clinically or pathologically as any other recognizable condition. Okay, so it increases the risk of cancer is increased by 6 to 9 times in erythroplakia. See, and I told you the reddish patch cannot be not characterized by other conditions. Again, it cannot be rubbed off like leukoplakia. The most aggressive type, this you have to remember, it's important, it is speckled leukoplakia, okay, or erythroleukoplakia. It is a combination of both. It carries the greatest risk for malignant change. So the management of these lesions, it is challenging. However, we can just say that for erythroplakia we can avoid the risk factors, right, and we can go for an excision. Factors associated with increased risk for malignant change in a pre-existing dysplastic lesion, right? So female sex, size more than 200 millimeter square, non-homogeneous lesion, non-smoker, presence of multiple lesions, and location, example lateral border of tongue or floor of mouth. These are the factors associated with increased risk for malignant change in pre-existing lesions. Now moving on to submucous fibrosis. So this results due to chewing of betel nut. Okay, there is a hypersensitivity reaction. Okay, this leads to fibrosis. Okay, the hypersensitivity reaction leads to fibrosis. Now because of the fibrosis, there is inadequate mouth opening, which in turn it will lead to poor hygiene, right? So this will result in increased risk of causing cancer. Moving on to the staging of oral cancer. So we have to be familiar with two terms, that is the tumor thickness and the depth of invasion. So tumor thickness is the thickness of the tumor extending from here up to downwards, that is extending from the surface to the deepest point, and depth of invasion is the extent of the tumor that is beneath the surface, that is from the basement membrane to the deepest point. So that is tumor thickness and depth of invasion. Now moving on to the T classification. So TX means it cannot be assessed. So the patient cannot open his or her mouth, or the patient has had a prior chemo radiotherapy, so the tumor has been downstaged and now you cannot assess what has been the initial stage, right? Now T1 means the size is less than or equal to 2 centimeters. Okay, before that, TIS means it is carcinoma in situ. T1 is tumor less than or equal to 2 cm, depth of invasion less than or equal to 5 mm. T2 is size less than or equal to 2 cm, depth of invasion is 5 to 10 millimeters. Okay, right. Now T2 can also be tumor size of 2 to 4 cm and depth of invasion less than or equal to 10 millimeters. T3 means size more than 4 centimeters, okay, or depth of invasion more than 10 millimeters. Okay, so that is T3. Now T4 means there is involvement of adjacent structures. Okay, now T4A means it is resectable, and T4B means non-resectable. I just want you to remember that much. T4A is resectable, T4B is non-resectable. There is involvement of adjacent structures. It is a moderately advanced or very advanced local disease. So that is the T category. Now moving on to the N category. So NX means the nodal status cannot be assessed. N0 is no lymph node involvement, we know that, right? N1 means single ipsilateral lymph node less than or equal to 3 centimeters. Okay, here T categories, it was 2 centimeter to begin with, right? Okay, less than or equal to 2 centimeter was T1. N1 is single ipsilateral lymph node less than or equal to 3 centimeters. Okay, next is N2. Okay, so N2 we have N2A, N2B and N2C. So N2A is single ipsilateral lymph node 3 to 6 centimeters. N2B is multiple ipsilateral lymph nodes less than or equal to 6 centimeters. N2C, okay, so N2C means till now it was ipsilateral, so N2C it will be bilateral or contralateral lymph nodes less than or equal to 6 centimeters. Okay, so it is within 6 centimeters, N2. Okay, so N3, when we get to N3, the size is more than 6 centimeters. So N3A is size more than 6 centimeters or extranodal extension negative. N3B is any extranodal extension positive, clinical or radiological. There can be matted nodes. Okay, it can be attached to skin. Okay, so that is N3B. Now moving on to metastasis. So MXs cannot be assessed again. MXs cannot be assessed. M0 is no mets and M1 means distant mets is present. Okay, so that is the staging of oral cancer. This is the TNM staging. Now there is a prognostic staging grouping that is from the AJCC. This is shown in table 53.3. Just take a look at that, right? Okay, so discussing the pathology of oral cancers, I will be talking about the tumor grade, right? So according to the WHO grade, oral cavity cancers, we can classify it as well differentiated. There is grade 1, moderately differentiated, grade 2, or poorly differentiated, grade 3. Okay, so well differentiated, these are less aggressive, right? And they have more number of keratin pearls. So what you see here is the keratin pearls in this slide. Okay, so well differentiated tumors, they have more number of keratin pearls. However, the poorly differentiated counterparts, they metastasize easily, okay, more readily, they can infiltrate more readily, and they have no keratin pearls, right? So that is the difference you have to remember, and these have worse prognosis. So that is done. Now moving on to examination, investigation, diagnosis and workup. So we need to do a histopathological diagnosis if the lesion is suspicious for malignancy. So there's no doubt about that, right? Now, prior to this histopathological diagnosis, prior to taking a biopsy, what we have to do is take a thorough history, and we have to examine the oral cavity, the oropharynx, and we have to examine the neck for any lymph node involvement. Okay, now radiographic assessment is also mandatory, and some centers sentinel lymph node biopsy, SLNB. This has become an established technique, especially it is for investigation and staging of T1, T2 cancers that have no clinical or radiographic evidence of cervical metastasis. Right now, positive SLNB means we need to do further neck dissection. Right now, sometimes when biopsy is not possible in an OP setting, or when the extent of the tumor cannot be properly assessed with any clinical examination in an awake patient, we do examination under anesthesia, that is EUA. Okay, so this can support the treatment planning, decision making with regards to access, extent of resection, and reconstructive plans. Right, so now I'll move on to the workup of this patient. So to work up a patient with oral cavity cancer, I have to first of all confirm the diagnosis, right? So I have to confirm the diagnosis by taking a biopsy, incisional biopsy, okay, or it is also known as a wedge biopsy or an edge biopsy. So we take the biopsy from the edge of the tumor and not from the center, because the center is necrotic. So we take it from the edge of the tumor. Now for the neck lump, so if there is neck lymphadenopathy, the first line biopsy is FNAC, right? Yeah, it will also help in differentiating between thyroid malignancy, oropharyngeal and oral cavity lesions, and lymphoma. Now for staging, we do contrast enhanced CT of PNS, neck and thorax. So why? Because the most common metastasis is to the lungs, so we have to take a CCT of the PNS, neck, as well as of the thorax. Okay, so other imaging modalities are MRI. So MRI will help to define the primary extent of the oral cavity cancers. It gives more information on the perineural spread and bone marrow invasion. It is also helpful in detecting metastasis, but it is comparable to that of CT. Now PET-CT, it is not the first line imaging investigation for head and neck cancer. It is usually restricted to detecting distant metastasis, tumors of unknown primary, post treatment surveillance and such. So that is that. Now we won't be going into the details of the other modalities, but these are the main things. Now as far as the management is concerned, we have surgical management or with adjuvant radiotherapy or chemoradiotherapy. Okay, so we will be diving into all of these things. So first of all, let us go with surgical management. Okay, so surgery, what we do is a wide local excision. Okay, so what we aim for is an R0 resection. So R0 resection means microscopic freedom from the disease. Okay, so at a microscopic level we need freedom from the disease. So that is what the surgeon aims to do. Now the wide local excision, I told you, it is with 0.5 centimeters margin. Okay, so we have different approaches. So let's say there is lip cancer, okay, and it involves less than 1/3 of the area of the lip, then we go for a wide local excision with primary closure. Okay, say 1/3 to 2/3 of the lip is involved, then if we do wide local excision with primary closure, we will get a microstomia. Okay, so we cannot go for this, we will go for something known as Johansson stepladder pattern, and for more than 2/3 involvement we can go for flap reconstruction. So most tumors can be removed via a transoral approach. Okay, but some cannot be resected safely without an access procedure. Okay, so we use different approaches for wide local excision. First we have the Weiser approach. So this is used for resection of the mandible and floor of mouth. Then we have the lip split approach. So this is the lip split mandibulotomy we're talking about. And we also have the Weber-Ferguson approach. So this is for maxillectomy. Okay. Now lip split mandibulotomy, it is the most commonly used approach in wide local excision. Look at this image. This is the lip split mandibulotomy. This is the incision, and this is an osteotomy made. So an osteotomy is made in the mandible in order to swing it laterally, thus facilitating access. Okay. I think you can appreciate the images. Alright. Now next is the Weber-Ferguson approach. I told you this is the incision that we make in Weber-Ferguson approach. It provides excellent access to the maxilla and if extended infraorbitally to the periorbital areas. The next step in surgical management is mandibular resection, and the indication is the involvement of the mandible. So if the mandible is involved, we go for mandibular resection. There are two types of mandibular resection. It can either be segmental resection or rim resection. So segmental resection means full height of the invaded segment of the mandible is removed, such that there is loss of continuity of the lower border. As I've drawn in this picture, the full height of the invaded section of the mandible is removed. Okay, that is segmental resection. Now here what you see is, here the lower border is remaining, right? It is not removed. The lower border, the continuity of the lower border, it remains. So that is known as marginal mandibulectomy. Okay. Now lymph node involvement. For lymph node involvement, we have to do lymph node dissection. So we need to take a look at the lymph node levels in the neck. Okay, neck lymph nodes. So see here, you can see 1A, 1B. So these are the submental and the submandibular lymph nodes. 2 is upper deep cervical, 3 is middle deep cervical, 4 is lower deep cervical, 5 is posterior triangle. So 5A is superior and 5B is inferior, and 7 is mediastinal lymph nodes. Central compartment lymph nodes, I want to tell you, it is also known as the pretracheal and paratracheal lymph nodes. It is also known as the Delphian lymph nodes, and it is important because these are the first draining nodes from thyroid cancer and laryngeal cancer. So we do a prophylactic neck dissection in early stage disease. That is, early stage means T1 to T2, right? So a prophylactic neck dissection has better overall disease specific survival, right, relative to patients who have a watch and wait policy. Okay, and a therapeutic neck dissection only when a metastasis become apparent. So Bailey says that prophylactic neck dissection is better. Okay, so prophylactic neck dissection, what we do is a selective neck dissection, which is a SOHND, that is supraomohyoid neck dissection. So supraomohyoid neck dissection involves level 1 to 3 lymph nodes. Okay, so I showed you that image, right? So see, this is the superior belly of the omohyoid. So above it is the level 1, 2, 3 lymph nodes. So that is supraomohyoid neck dissection. Alright, now sentinel lymph node biopsy, this can be utilized also. It can be utilized as a staging investigation. Now this will help in detecting occult metastasis and any unexpected contralateral drainage. Okay, so what are the carcinomas with contralateral lymph node drainage? The angle of mouth cancer, lip cancer crossing the midline, carcinoma tip of tongue, and soft palate carcinoma. These are the carcinomas with contralateral lymph node drainage. Now what are the different types of neck dissection? This is important. Okay, so first we have radical neck dissection. It was described by Kreil. So in radical neck dissection, level 1 to 5 lymph nodes are removed. Okay, now along with the level 1 to 5 lymph nodes, spinal accessory nerve, internal jugular vein, and sternocleidomastoid, these three structures, extra lymphatic structures, are also removed. Okay, now the catch comes here. Along with these structures, the tail of parotid and submandibular gland is also removed. So 1 to 5 lymph nodes are removed. Okay, extra lymphatic structures are removed, spinal accessory nerve, internal jugular vein, and sternocleidomastoid, and along with that we also remove the tail of parotid and submandibular gland. This you have to remember because it is asked in exams. Okay, so this is radical neck dissection. How about modified radical neck dissection? In modified radical neck dissection, level 1 to 5 lymph nodes are removed, the tail of parotid is removed, the submandibular gland is removed, but we save at least one extra lymphatic structure. So modified radical neck dissection type 1 means spinal accessory nerve is preserved. Okay, level 1 to 5 lymph nodes are removed, tail of parotid is removed, the submandibular salivary gland is removed, IJV is removed, and sternocleidomastoid is also removed. Okay, what is preserved? Spinal accessory is preserved. Okay, IJV and they are both removed. Now type 2 means two structures are preserved. Which are the two structures? Spinal accessory nerve plus internal jugular vein. Type 3 means all the three structures are preserved: spinal accessory, internal jugular vein, as well as the sternocleidomastoid. All the three structures are preserved. Now moving on to functional neck dissection. So functional neck dissection is a type of neck dissection when all the three structures are removed. When all the three structures are preserved. Alright, so what is lateral neck dissection? So lateral neck dissection means level 2 lymph node, level 3 lymph node, level 4 lymph nodes are removed. Now what is posterolateral neck dissection? So if you want to remember this better, just take a look at this image, right? So posterolateral, lateral is 2, 3 and 4. If 5 is also removed, then we call it posterolateral. So posterolateral means what all do we remove? We remove all these structures, right? We remove all these structures. These are removed in posterolateral neck dissection. Okay, now central neck dissection means level 6 lymph node is removed in central neck dissection. This is done in case of thyroid carcinoma with no mets. Okay, now discussing the complications of neck dissection. For any intervention, we have some common complications like bleeding and infection, which is also a complication here. Okay, now other than that, we can injure the nerves. So what are the nerves which are injured in neck dissection? So marginal mandibular nerve can be injured. It supplies the angle of the mouth. Next is the spinal accessory nerve. So if the spinal accessory nerve is injured, there can be drooping of shoulder, there can be shoulder dysfunction. We can also injure the hypoglossal nerve and the phrenic nerve. Okay, then another complication that we have is a carotid artery blowout. So in a carotid artery blowout, due to infection, there is rupture, there is blowout. Blowout occurs of the carotid. So this can lead to, if the carotid has a blowout, there will be bleeding. Now this can lead to death. Okay, so these are the complications of neck dissection. Now moving on to the last step of the surgical management, which is reconstruction. So regional and pedicle flaps include tissues from other parts of the head and neck, such as the temporalis and platysmal flap we have. Okay, we have those from distant sides. We have the latissimus dorsi flap, we have deltopectoral, and so on. Okay, I want you to remember that the pectoralis major myocutaneous flap, this is the most common used flap in head and neck reconstruction surgery. Alright, now Abbe-Eslander flap, this is for lip and angle of mouth reconstruction. I've mentioned this earlier on in this video, I don't know if you remember it, but this is for lip and angle of mouth reconstruction. It is based on the labial vessels. Now moving on to free flap. Okay, so what is free flap? This is a portion of vascularized tissue. Okay, so these are taken from one area and they are transferred to another area which is requiring reconstruction, and the artery and vein are anastomosed locally, so there is an independent blood supply for this free flap. For soft tissue reconstruction, we can use the radial forearm free flap or the anterolateral thigh flap. Okay, and radial forearm free flap, this is the most versatile for head and neck reconstruction. And before harvesting a radial forearm free flap, we do something known as the Allen's test. This is to check the radioulnar patency. So you can just look that up, right? Now, anterolateral thigh flap, I'll show you the image of harvesting the radial forearm free flap and the anterolateral thigh free flap. See, here you can see this is the anterolateral thigh flap, which is used to construct a left partial glossectomy or floor of mouth ablative defect. So here you can see how it has been reconstructed. Alright, now moving up, I'll show you the image. This is the radial artery forearm free flap. Okay, and here it is used to reconstruct a left lateral tongue defect. Okay, and here you can see how it has been reconstructed. Okay, so a similar tissue is used to reconstruct the area. Now, composite reconstruction, so we need to take a look at what is known as the fibular free flap. Okay, so this is used for mandibular reconstruction. That is all I want you to remember. Now discussing adjuvant therapy for the management of oral cancer. So adjuvant therapy includes chemotherapy and radiotherapy. Okay, so what are the indications for this? So if there are high risk features, okay, like extranodal extension, close or involved margins, lymphovascular invasion and perineural invasion, we can go for adjuvant therapy. Okay, now for radiotherapy, the indication is one major criterion or two minor criterion being followed. Now let us see what is this one major criterion and two minor criterion. Now one major criterion is the presence of extranodal extension and or involved margins less than 1 millimeters, or two minor criterion. So there can be closed margin 1 to 4.9 millimeter. There can be multiple involved nodes, largest node more than 3 centimeters, lymphovascular invasion or perineural invasion, and T3 or T4 stage. Now this would indicate the need for adjuvant radiotherapy. Now in high risk oral cavity squamous cell carcinomas, an additional benefit is conferred if we add chemotherapeutic drug to the radiotherapy, right? To the postoperative conventional radiotherapy, adding high dose cisplatin was found to be beneficial by studies. Now this chemotherapeutic agent is acting as a radiosensitizer, thereby benefiting the patient. Now what about immunotherapy? So we know that tumor can sometimes escape the immune response. Now there is something known as the programmed death receptor 1 pathway. So we introduce a PD1, programmed death receptor 1 inhibitor. Okay, so this is shown to prolong the survival in metastatic disease and in recurrent disease. Okay, so thank you and subscribe for more of these videos.